morning. Welcome back to Open Med School. I am Dr. Andrews, Professor of Medicine, Consultant Neurologist. Today I will be discussing about a monoclonal antibody, Rituximab. So let us see what is Rituximab. Rituximab is a anti-CD20 monoclonal antibody which is a chimeric IgG type. So what is meant by this chimeric? So chimeric means there are two separate parts are in the antibody. This variable region includes a mouse antibody and the rest is human. So here you can see a bird with one half is belonging to two separate genetic composition. So this is a chimeric antibody. So this will induce less immunogenicity. That is one of the advantages. So I said it is a anti-CD20. CD20 is expressed in most of the B cells, but not in the stem cell or in the mature plasma cells. So B cells are transformed into plasma cells, they don't contain. The antibody acts mainly by depleting CD20 positive B cells. So let us see how it acts. There are different mechanisms. One is antibody dependence cell mediated cytotoxicity, ADCC. Second is activation of the complement activation. Third, it activates the apoptosis. So these are the three different mechanisms by which one is ADCC, antibody dependent cell mediated cytotoxicity, complement activation and activation of the apoptosis. What are the uses of Rituximab? Rituximab is used in many rheumatological conditions, in vasculitis, autoimmune hemolytic anemia, especially the warm antibody type, either along with steroid or when the patient fails to respond to steroid as a second line drug. What are the contraindications? Absolute contraindication is reaction to any of the component of this chimeric antibody. So in acute infection or active infections, it should be avoided because it produces profound immunosuppression. Patient with cardiovascular compromise or a decompensated heart failure, again it is not given because this can produce hemodynamic problems at the time of infusion. All the patients who are being planned Rituximab should have a pre-treatment evaluation before starting the treatment. That is essential. So what are the tests that are routinely done? Vaccination should be updated except the influenza vaccine which can be given during treatment. Screening for infections is essential. Hepatitis, you should go for a hepatitis B surface antigen and hepatitis B core antigen. Evaluate for hepatitis C, HIV, and a baseline immunoglobulin level IgG, IgM, IgA. Chest X-ray should be taken. Serum electrophoresis can also be done. So these are the baselines. So most important is here to exclude active infection. Hepatitis B, surface antigen to core antigen, hepatitis C, HIV, then you may check the immunoglobulin level. Hope this point is clear to you. When you are giving, a pre-medication is done. So let us look into how it is infused. This is to avoid the infusion reactions, pre-medicate 30 minutes before the infusion. Usually give acetaminophen 650 to 1000 mg orally, diphenhydramine, chlorpheniramine, which can be given intravenously 10 mg or diphenhydramine 25 to 50 mg orally or IV. IV methyl prednisolone 80 to 125 mg. If the patient is on antihypertensive on the day of infusion, stop it to reduce the risk of hypertension. So pre-medication with antihistamines, steroids and paracetamol, and some people give famotidine S2 blockade also. This is said to reduce the incidence of the infusion reactions. Let us look into what is the dose. For most rheumatological conditions, it is 1000 milligrams, 2 doses, 2 weeks apart. In autoimmune hemolytic anemia, usually you give 375 milligram per 1 meter square body surface area. And this is repeated weekly into 4 weeks for autoimmune hemolytic anemia. So 375 milligram weekly for 4 weeks. In other conditions, 2 doses, 2 weeks apart. That is the usual recommended dosage. Subsequent doses may be given after 6 months depending upon the response, disease activity and B cell repopulation. Monitoring adverse effects are very important. Infusion reaction, especially anaphylaxis. So patient should be monitored throughout, and dose should be started around 50 milligram per hour. Dose can be increased or doubled after 1 hour to 50 milligram to maximum of up to 400 milligram per hour. So this is how it is infused. Patient can develop hypogammaglobulinemia, infection and hepatitis B reactivation, neutropenia. So if you are going to give repeat doses, check the immunoglobulin level. IgG less than 5 grams, you may go for other treatment. So the most important infusion reaction is development of anaphylaxis. They may start coughing, develop rashes, discomfort in the throat or breathlessness. So every facility for managing anaphylaxis should be there. So in conclusion, Rituximab is a powerful immunomodulatory agent. Use requires careful patient selection, screening, monitoring and pre-medication. Hope it was useful to you. Thank you.